about the shunts and the shunt materials, and also how to select the right shunt for the right indication. Well, I think this should be straightforward for most neurosurgeons and certainly for residents. I don't know. Let's see. Ramesh didn't mention this so well, but let's say I can briefly and very quickly tell about the history of the shunts. This is from a journal in 1951, so nearly 70 years ago, stating that at that time, the most popular procedures were the ventricular cystonostomy of Torkelson and the open third ventriculostomy of Dendy for obstructive hydrocephalus. And for the non-obstructive, the communicating hydrocephalus, it was the coagulation of the choroid plexus. But in that article, for the first time, they mentioned that there are now ingenious methods for shunting the excess of CSF from ventricles or spine to another space. And that's true because it was in 1949 when these two neurosurgeons, Eugene Spitz and Francis Knudsen, implanted the very first ball and cone valve system in a hydrocephalic child. So it was in Philadelphia, and Eugene Spitz went on with this, but Frank Knudsen became chair of the Case Western Reserve University in Cleveland, so he moved out later on. But that was one, but they had a lot of technical problems with that. There were bleedings, these shunts clogged all the time, they needed revisions. It was quite some, and they had embolisms, so it was a difficult procedure. And it only changed when this man, John Halter, and his wife, Claire, had a child, Casey, a son, who was born with spina bifida, quite severe thoracic lumbar type with myelodysplasia, and developed hydrocephalus. And he came under the care of Dr. Spitz in Philadelphia. And they did punctures of the soft spot, what was very typical, just to drain always the high pressure. And Dr. Spitz explained to him that there was a possibility to put in a drain, but also explained the high risks of that procedure of that time. And that set this man, who was a mechanic, he was not a doctor, was not even medically educated at all. And he developed a slit valve mechanism from polyvinyl chloride, very similar to the nipple of a baby bottle with milk, that when it is very small, only little milk comes out, and if it is larger, some more come out. So he developed that slit valve, but then they realized that polyvinyl chloride cannot be sterilized because of the high temperatures. This would completely deform. So it was working, but it didn't work out well because it could not be sterilized. And then he came in contact with the Dow Corning company, who had a new material, silicone, and they provided that to him for free, some catheters, tubings of silicone. And he started to do the same with this new material, silicone. But unfortunately, Casey's condition deteriorated, and they couldn't wait. So he was just a week too late, finishing his silicone shunt. Casey needed, because it was more than daily fontanelle punctures. And so he received this ball and cone Spitz and Knudsen devised catheter. But during that surgery, he had severe complications and was left with severe brain damage. Later on, and 2 years later, during a revision, he received the shunt of his father's, but he died nevertheless a few years later of the complications of that brain damage. So this really changed, and John Halter worked on, and he founded a company. He wanted to have this not available only for his son, but for the whole community. And indeed, as you know, the Spitz-Halter shunt, one of the first types, is actually still available. And he developed a lot. He became the CEO of a large medical company. So this was more than serendipity. It was willingly doing something out of your even scope of knowledge, just out of despair. And this was the typical way of surgery. It was above and behind the ear, and then to the vena cava, the caval vein. That was a typical procedure of that time. And between this first implantation in 1956 and let's say the next 5 years, more than thousands of these shunts have been implanted. It's very odd to see that that history sometimes repeats itself, and that is the story of the famous author Roald Dahl. He had a son, and a very young son. He had 2 daughters and a son. And in 1960, while they were walking on the street, they wanted to cross the street and were hit by a taxi. And little Theo, 4 months old, was severely injured. And he developed a post-traumatic hydrocephalus. So he received that shunt, the Spitz-Halter shunt. But it clocked several times. So in the first year, he had 7 revisions. So he wrote to his mother in England and said, there should be better shunts that are not so easily clogging. And she wrote him back and said, well, we have here in England a shunt called the Pudence shunt. That was Robert Pudence, who developed also a slit valve system. It was sent to the US and it was implanted. But unfortunately, that also clogged and needed a revision within a month. So Dahl started to work with a toy maker, Wade, and a young neurosurgeon, Till, and just on their drawing boards and in their house, they designed a shunt. And they managed to do that. So they patented it, actually, and it is the Wade Dahl Till shunt. It has been implanted in over 3,000 patients. And this lower image here, you see the Wade Dahl Till shunt that was explanted in an adult more than 30 years after primary implantation as a child. And because of that, at that time, it didn't function anymore, but it did well. So if we look to that, we see in those years, that is 70 years ago, 65 years ago, initially with Spitz and Olsen had this ventriculocaval shunt. After that, first came the ventriculopleural shunt. And just a year after that, the ventriculoperitoneal shunt became available. So in 1955, it was another kind, not ball and cone, but slit type of valve that was devised by Halter, but at the same time, a little later actually, by Robert Pudence. They improved that to either being a proximal or a distal slit valve, and at that similar time, 1959, finally the diaphragm valve was developed. And it took another 10 years, and then the first lumboperitoneal shunt was ever inserted in a human. So very briefly, the history of that. To be honest, at the moment, and probably that's already not true anymore because it goes very quickly, but there are 249 different shunt systems available in the world, and altogether they have 486 pressure settings. So what we can learn from this is simply the perfect shunt does not exist. And because of that, many neurosurgeons say, come on, it doesn't matter at all. It doesn't matter what kind of shunt you do. You can put the Chabra shunt or any other type of shunt, it's all the same. And to be honest, there is only one really randomized study comparing different shunts with each other. And now we have the developments from the usually fixed settings that we always had versus the now programmable, adjustable systems. Still, with everything what we do, over drainage is the biggest problem. And with over drainage, also obstructions and so on. From this one study, actually, they say the gravity-assisted valves that now have come into the market about 15 years ago seem to be superior to the other ones. But nevertheless, if you look in a single institution, the choice of shunt that they use is very often industry-driven and not based on any physiological parameters of the patient. So let's look to the system components very quickly. We all know this is basic stuff. So you have a proximal catheter for the inflow of the CSF, then you have also a distal catheter bringing it to some kind of cavity in the human body, usually the abdomen or the heart, but it can also be others. And of course, in between, then that valve mechanism that regulates how much of excess CSF is drained, yes or no. So that is the most important part of the shunt components, the valve. Because this controls how much CSF will drain. And yes, of course, we know it is now not only a valve, there are a lot of accessories that can compensate for gravity, that control the siphoning. And now we have even systems that regulate only the flow based on the secretion of CSF. Some of these systems are offered by the manufacturers as one-piece design, but usually, and I think most of you will do that, you have to put it together during the surgery. So you use connectors to connect the proximal catheter to the valve to the distal catheter, bring it under the skin. So custom made by the surgeon during and in the OR. More or less, every single shunt that we have now is based on the principle of differential pressure. So that's a pressure between the proximal end, which is in the ventricle, and the pressure at the drainage end, being in the heart or in the abdomen or pleural cavity. And neurosurgeons should at least select these valves based upon the age of a patient, size of ventricles, pressure, and maybe also on the etiology of hydrocephalus. But in most of the times, this will not be the case. And yes, we know that sometimes if you have used and selected a shunt with a differential pressure, it turns out that it either underdrain or overdrain. So you have to redo the surgery and put in either a higher or lower pressure valve. So this was standard procedures for us. To avoid that second procedures, then there was this development of adjustable valves. These were still differential pressure valves, but with a magnet from the outside, you could change the individual pressure settings, let's say from low to medium, from medium to high, and vice versa. So this could already avoid second surgeries. And also the Orbis Sigma valve, the flow regulator valves, were saying they could adjust themselves to the need and avoid overdrainage. Typically, if you look to the available shunts, they are delivered in 3 to 5 ranges, low, medium, and high pressure, and some offer very low and very high also. These are fixed. The problem is that there are no voluntary industry standards on how to measure pressure or flow characteristics of a shunt. Every manufacturer does it by himself or herself. And any kind of standards that has been described are never been adopted universally. And now it comes, there are not even industry defined values for each of these ranges. So if you have a medium pressure valve from one manufacturer and a medium pressure valve from another manufacturer, they could have completely different opening pressures. That makes it really difficult. But also that it is not a very stable thing, because due to the limitations in making these shunts, in this manufacturing process and quality control, it is not even possible to make all the shunts. If one manufacturer make 100 shunts called medium pressure, several of them will not have, they will have different opening pressure. There's a whole range. Partly that will be into the low, partly will to be into the high. So it really changes a lot. This altogether simply makes the choice of a shunt valve very complicated. And I remember when in the early 80s as a resident, I developed a self-adjusting valve. And actually that was also when I met John Holter personally, because he visited me. I discussed it with an engineer. And the engineer was looking at this and said, these are very primitive differential valve pressures, and they are not stable at all. You are not implanting these in humans, do you? He couldn't believe that we would use this really on our patients. He said they are so primitive. But it's the reality. This is what we have. So let's look still what we have: 3 different types of valve mechanisms. The slit valve, the famous old Holter and Puden slit valve. That's a slit in the catheter. And it will only leave drops out when the fluid pressure in the lumen of the catheter is high enough. And that depends, so the opening pressure depends on, well, the stiffness of the silicone, the thickness of the wall, of course also the length of the slit. The problem with slit valves, please remember this, is that aging of the silicone rubber and also tempering and managing that during the surgery is absolutely altering the performance of this type of valve. So it is very insecure what type of pressure management and differential pressure is really inserted here. But these are still available. Diaphragm valves are very common. It's simply by the differential pressure that we have between proximal and distal, a flexible membrane will move. So if the pressure is high enough, it will push this flexible membrane up, allowing CSF to flow through. And when the pressure is lower again, then that membrane comes back in its old position and closes off the shunt, the valve, until, of course, the pressure increases again. And then the third type is still this spring-loaded ball and cone valve. So very much actually as Spitz and Olsen had, but they didn't have the spring-loaded ball. So that means it's spring, could be a flat or coiled spring. And it's usually from synthetic ruby, because it's nice and soft material, that is holed in a cone-shaped orifice. So when the CSF pressure is high enough, it pushes this ball against the spring. And of course, it depends on the stiffness of the spring, how high the pressure needs to be. And then if it pushes against the spring, CSF can go out. And they are still very common, because they are not so much a problem with aging of the material. It's usually metal also involved. And the ball and cone and springs system has not the high tendency to clog, for example, with high protein or with still some red blood cells in the CSF. So they are still very popular valve mechanisms. Well, and then of course we have these programmable valves. That means that it is, well, we call it adjustable, I would say, is better than programmable, because they are of course not self-adjusting. The only thing is you can do that when the child or the patient comes in your office with a magnet. You can change one pressure setting to another. The moment you have changed it, it is again a fixed differential pressure valve, until you readjust it again to another value. But the moment you stop adjusting it, it is a fixed pressure. It cannot adjust itself, not at all. And therefore, in some of these cases, you need several readjustments before you really have the desired situation of your patient. It's usually with a magnet. Sometimes they can do it also magnetically, lifting something up and then mechanically turn it. But they are adjusted by a rather strong magnetic field locally. Problem is that they are susceptible by spontaneous change, for example, in an MRI scan, but also has been described that they can change by certain toys that children play with that contain magnets. So after they are exposed to a strong magnetic field, you have to check them again. These adjustable valves still have a siphoning effect. They are differential pressure valves. So they just react on the difference between proximal and distal. And if it sucks out, so if the distal is negative, then you get this siphoning effect. And therefore you either need a compensating mechanism for gravity or for anti-siphoning. And also they don't compensate well, all these differential valves, for acute changes. The daily activities, sporting, bending over, walking, being active or sporting, coughing, all these things are not well adjusted. Valves can't react on that. They just see that there is a difference between proximal and distal. And therefore, they still are prone to overdrainage. There is one type, this orbis sigma, the flow regulating valve. It keeps the CSF flowing through the valve close to the rate of CSF secretion. And that it does indeed, regardless of the patient position or anything, or other positions or coughing that usually promote overdrainage. The problem is that in the normal range of secretion and flow, they simply act not as a variable flow restrictor, but exactly like a differential valve pressure, differential pressure valve. You all know that we use some reservoirs, a borehole reservoir or an antechamber placed between the proximal catheter and the valve. You can use this for diagnostics. You can even inject also medication into the brain. You can sample CSF to see if there is an infection. So we all know that. But these are the bubbles that the patients usually feel. The problem is that we learn, maybe nowadays not so much, but if you pump it, if you push it and you push it down and it stays down, it doesn't come up, that points to a proximal dysfunction. On the other hand, if it is very difficult to push it down, maybe there is a problem in the valve or in the distal end of the catheter. Unfortunately, this is an absolutely unreliable thing to do. It is covered by the skin. It is not really reliable. Depends on the pressure. It doesn't really point out. The same is that, at least during my residency, many neurosurgeons recommended at least 20 times of pumping of the reservoir daily to keep the shunt open. This is completely wrong. You should avoid that. Never do that. The normal function of a shunt will keep it open. If you pump it, you will overdrain, and you will actually, by this pumping, suck some plexus into the proximal catheter and can cause obstruction. So these are the little problems that we have with that. Shunt problems? Some say, oh, we don't have problems. Most patients do well. Yeah, indeed, 80% of the patients do fairly well, but that has nothing to do with the fact that they are such beautiful pieces of mechanics. It only points to the fact that the human body is capable of adapting to even such a device as a shunt. And despite all the newer developments that we have, antibiotic impregnated catheters, these gravitational valves, the telemetric pressure measurements, all these, still the risk of revision and also infection is and remains the major challenge in shunt surgery. This was a study from Denmark. They had a series from 1958 to 1889, and then looked when they had the more modern shunts and shunt protocols for insertion. They saw there was, of course, the follow-up time was shorter, but there was a tendency that the overall shunt survival was a little bit longer, but only a little bit. And actually, if you look to the figures, it was not even statistically significant and also not clinically relevant. Still, overall, 4 out of 10 had a revision, and 2/3 of them fell within the first 6 months after insertion. And also the 1 and 5 year shunt survival probabilities were exactly similar. So they were very close. So this was not real progress. We know all these statistics, you can see that. Still, valve defects and proximal obstructions are the most frequent causes of revision, usually pointing to the fact that there is a kind of overdrainage. The only difference has been shown in the gravitational shunts. They show indeed a higher long-term shunt survival, so less revision, and mainly because they have less revision because of overdrainage. And that means less obstruction, no subdurals, so all of these. And the tendency, indeed, the ventricle stays a little bit larger with these shunts. But so the shunt survival is longer. That's the only difference that we can find in the literature. Now, back to the problems. We have problems with our posture of standing, sitting, laying down, being active, yes or no, but also the vasogenic problems. What we don't realize that during the night, we have periodic small increases in blood volume in the head. And you just heard the lecture by Ipachirian. I think that indeed has to do with the cleaning and the cooling of the brain. But the problem is that this nocturnal cerebral vasogenic wave activity that occurs so several times simply leads to more drainage of CSF because the shunt doesn't know that it is a vasogenic wave. They just see that because of the increased blood volume, the CSF pressure is higher. The same is when the patient strains, is active, lifting something up, or is coughing. This all pushes CSF out of the ventricles in every single valve system there is nowadays. And yes, the posture, we call it siphoning, overdrainage, and overshunting as being the same, but it's not. Siphoning is postural phenomenon because of the hydrostatic pressure when you're standing. Overdrainage and overshunting refers to the CSF that is shunted, both by postural, but also vasogenic effects. That's the difference. And because of this overdrainage, we see proximal shunt obstruction, headache, slit ventricle syndrome, subdurals, extradurals, secondary craniosynostosis. Many neurosurgeons say, oh, well, I occasionally see some problems with shunts. I can tell you, if you really deal more frequently with shunt, you know, and you have seen probably most of all these problems. And of course, then they developed siphon resistive devices because they react to the hydrostatic pressure. And they indeed, but they communicate with the atmospheric pressure. And therefore the problem is, if the child has a tight skin over that device, then this—
André, it's 30 minutes now.
Already? Oh, I thought that—
Already.
Oh, I'm very sorry. I have to quickly go there. And because I wanted to at least end in 2 minutes on how to choose a shunt. These are all the different shunts, and I have nothing to disclose on any being influenced by these. In premature babies and infants, but also in comatose patients that will remain recumbent, choose a fixed and small fixed differential pressure valve. Could be the mini NEF system by Miko, or the micro valve by Kopman, or this button valve by Medtronic. That doesn't matter, but that is the best way to do. In the younger children that start to become mobile, choose a shunt that has some, at least involved here, the siphon guard. The Pedigaf has also a siphoning device in it, and the same here with the delta chambers. That's important. That's typically also for all patients with post-hemorrhagic and post-infectious hydrocephalus. If you see the older children, and also in adults with post-hemorrhagic, think of subarachnoid hemorrhage and post-traumatic hydrocephalus, choose these, but then the larger ones, but again with this anti-siphoning device in it. There is one difference, and that is in adults with normal pressure hydrocephalus. That is an indication to choose an adjustable valve. If you follow these steps, then we can say now that we still see some patients with problems, but at least for the last few years, we do not have problematic patients anymore. So thank you for your attention. Sorry for taking the time. I was watching the clock not rightly.